said, yes, my name is Fiona and I am working in CH09 in a residential unit. So I'm going to talk to you today about frailty and falls. It is a massive topic in and of itself, so I've tried to condense it as brief as I can for you so you can get an outline of it. So the first area, like all of us with our evidence-based practice, we have to define frailty, look at the theories to understand it a little better. I'll have a little look at falls and the fear of falling, and then I'm going to look at Ireland's response to frailty. In particular, my dissertation focused on educational frailty as well. So I'll just talk a little bit about a few of the findings that I made. So without further ado, we'll go, So we know that the care of our older population is gaining critically attention, and none more so than when COVID happened. And it was ironic because I was studying frailty and suddenly it was put into sharp focus, frailty around COVID and the resources on our ICU beds and stuff like that at that time. So our older population, as we all are well aware, were the most impacted initially and to some degree still are. Back in 2015, the World Health Organization on Aging advocated that we position our healthcare services and needs of our older population with conditions such as frailty, and that we educate all of our healthcare personnel or professionals together. So rather than educating in silos and one at a time, that we actually all educate in a combined group for something like frailty, which targets all areas really. And in Ireland, our older population at the minute is going to increase by 63% into the year 2030. And then the older old is going to increase even more from 85 to 94. So that's a staggering increase. And it's a huge demographic shift in our society. So we have to learn, obviously, we want to manage it. And the society that can adapt to those changes will flourish and reap the rewards. But really critical in that is that we need a skilled and educated workforce in the field of gerontology, which is essential to our health service, but all health services. So the definition of frailty, it's a little bit scientific, a little bit chunky, but it's the main one used. And there's two main people that you'll hear in the frailty research and literature. But this definition is called a state of increased vulnerability to poor resolution of homeostasis after a stressor event and a consequence of cumulative decline in many physiological systems. So as we all know, an older person who's working really hard and plowing through life and gets to 80, 82, 3, little areas, maybe a bit of incontinence, maybe polypharmacy, had a fall, and all their systems just kind of collide and not collapse, but they are hard to get back to their original status due to this knock-on effect of something maybe minor like a chest infection. So that is a rough explanation of that definition. But frailty is influenced by the frailty syndromes, which we're looking at, which is our cognition, our delirium, our polypharmacy, our incontinence, our falls, poor nutrition, and what we've really seen now is our social isolation and deconditioning effects, which we are seeing from the cocooning from the pandemic. Okay, hold on, I've gone too far there. Let me just go back. My tongue. Okay, so it is a dynamic process, frailty, so it's not fixed, and it is influenced by environmental, biological, behavioural, and social throughout a person's lifetime. Okay. So the outcome of frailty for an older person is really the difference between independent to dependent living, or somebody who is mobile becoming immobile. So we all would agree we want somebody to maintain as much of their independence as is possible. So like I say, it is influenced by those factors of our cognition or polypharmacy. But if we think of it like, so it's not a fixed state, but it is a transition state. So frailty goes between 3 states. So if we think of it like it's, our first one is our robust health. I'm sure we all know people in their 90s who have really good robust health. And then somebody who's maybe in their early 70s who could be advanced in their frailty. Then we go into our pre-frail state, when they're just starting to show little areas which are declining in their systems. And then thirdly, it's a frail state. So a person can alternate between these known states from robust health to frailty. And the transition from robust to pre-frail to frail is reversible if we identify it early. So we have to pick up on it early, intervene in it earlier, and that can help somebody. However, if we don't identify it in time, that irreversible state for an older person can stay in the frailty state, and then we can no longer, we lost the window, so to speak, to get them back out of that frail state. So our healthcare models, which we've seen, and the stress and strain, they've all been put under recently, usually in older persons, react to crisis interventions for the older population, such as our falls, fractures, acute confusion, delirium, disability, and social isolation. So because our older population is aging more, we've got a bigger demographic, they have more complex comorbidities, they're the intensive users of the healthcare system. So it seems reasonable that the older person's care on entry to the health service is to identify and manage frailty and try and pick up on things maybe quicker than maybe what we could have picked up on to try and treat to alleviate that. Okay. So the next little area is the frailty theories. Now, there is so much written on this, and I've tried to keep it as really concise as I can to make it digestible for everybody. So in all of the frailty research and literature, there are two main frailty models, and it's the phenotype model and it's the frailty index model. The phenotype model is actually really quite simple. It's not that hard, as in it was developed by Freud in 2001 and was one of the landmark studies that actually paved the way for frailty. It's looking simply at if you have there's 5 physical components there, and so it's unintentional weight loss, self-reported exhaustion, weakness, slow walking speed, and a low physical activity. So if you beg your pardon, so if you have 1 or 2 of these, this is showing a risk for progression into frailty. But if you have 3 of them, that shows you're in a frail state. And obviously, if you've none of them, you're not in a frail state. So if this is one of our theories, what can we do about it? Which is what we all want to know ultimately. How can we treat this, fix it? What can we do? So according to the phenotype model, Freud is saying, yeah, of course, if we improve somebody's nutrition, if we improve their physical function, and if we improve their psychological status, this can help somebody. So the second one, which is the Frailty Index model, it's a little bit more mathematical, and it was developed in 2001 as well by Minsky, who's a mathematician, and Rockwood. Now, Rockwood is the power horse. I'm sure everyone has heard of him. He's in Canada. He's got an app. He's on Twitter. Really good to follow, actually. Gives really good insights into frailty, especially during the pandemic. So this is just a little bit more mathematical, and I really am not going to go into it much, but it's just safe to say the Frailty Index is calculated based on the presence or absence of 32 age-related health variables. So through the course of the lifetime, that could be cardiovascular, hypertension, COPD, respiratory. So there's a course of 32 age-related deficits. And therefore, the number of deficits is divided that somebody may have by that total number of deficits. And that will give you your Frailty Index calculation. So somebody with 8 deficits or more is frail. Pre-frail is somebody with 4 to 7 deficits. And 0 to 3 is somebody that they're not frail. So a deficit is more common as you get older and discuss more unsatisfactory outcomes. So say hypertension could count as frail, as a deficit, but not white hair. However, that's debatable with all the hairdressers being closed at the moment, so who's to say? So according to the Frailty Index, what can we do? Well, what the Frailty Index is saying, well, we can enrich the physical deficits, which in itself sounds quite simple, and it's probably a little easier than actually doing it. Treat underlying medical conditions and prove the physiological reserves for somebody. And that's really those 2 key models. But now I'm just going to briefly look at what we actually see in everyday practice. And in this audience, I'm sure people will obviously be aware of the comprehensive geriatric assessment, which is really the gold standard for managing frailty. Its aim is to provide a person-centered perspective of an older person and assess their physical, environmental, psychological areas in a specialist care. So it's basically targeting those areas. So if somebody's living on their own and they're falling more, or there's an incontinence, or they need social support or daycare facility, targeting where they need, because we want our older persons to stay at home. Our older persons want to stay at home as much as possible. So that really is what we would anticipate. And there's nothing that will pass now it is much more costly. You've got a geriatrician, you'd have all the multidisciplinary members of the team, the pharmacists, physios, OTs, specialist nurse. So, but however, when it targets it, it's very, very effective. The clinical frailty scale really is the tool that everyone will be familiar with. And that was further developed on from Rockwood and the Frailty Index. And I'm probably saying this a little bit more because to understand where we get our tools, when we do kind of have to understand the evidence behind it and a bit of to understand what works in practice. So all those 2 other models were good, they're not really used very widely in practice, probably a bit more in research, but not so much in our practice. So the clinical frailty scale was an easier tool that was developed by Rockwood. It's very practical to use. It's got a score ranging, which I'm sure from 1, which is very fit, to 9, which is terminally ill. And where I work in the residential care, you wouldn't see anyone around 5 is becoming frail. 6 is probably our best residents, who would be around 6, and they would even need some supports about them. But a lot might be around the 7 category, which would be quite severely frail. But it doesn't incorporate a social or a psychological domain. And the frailty really is showing up now, this social frailty and this cognitive frailty. And none of the tools really go in depth for that. And we need to look at that as a much bigger component. And I'm sure more research is going to come out of this, really, of what we're seeing with our older people who have to be restricted in their movement and cocooned. So the CFS tool, it does require clinical judgment of frailty. It's designed to be used in tandem with the comprehensive geriatric assessment, but that's, let's be realistic, that's not always possible. But most nurses will be familiar with the tool, and it's pictorial, it's written in bold, it's got an app as well, a clinical frailty scale app I've downloaded on my phone, and it's 9 questions. And over in the UK, they're using, in care homes, healthcare systems are using this app to judge frailty. So it is, yeah, it's a good one overall. So this is one of the models, and I won't go into it, but if anyone wants to have a look at this later, it kind of captures all the different elements of frailty and really showing it like a big jigsaw and how it all connects together. So you've got your biological, your resilience, the social and community networks, your living conditions, and your individual factors. So it's a big piece of work. And this is developed by Clegg et al. And he's really well known over the UK, all around frailty. Any of his works are really good to read. So that just gives you a really good description of going, oh my God, I didn't realize, where they lived, or people who live in rural settings with no family connections, or poor isolation, like loneliness. Over in the UK, I think originally back there, they actually had an MP who addressed issues on loneliness, such was the physical impact of it. So moving along, I'm just doing a brief bit of falls, and falls does relate to the whole frailty, as we're looking at the polypharmacy, cognition, mobility. Falls is our big thing, which a lot of us will see. So where do we start with a definition? So a definition of a fall is described as an event which results in a person coming to rest inadvertently on the ground floor or other lower level with or without a loss of consciousness. So a fall is often presented as a significant difficulty for the older population, and it's one of the presentations of the frailty crisis. Our human gait depends on the complex interplay of everything. So simply walking pulls on all of our systems, our cardiorespiratory, our nervous system, and our musculoskeletal system. So it's something, obviously we learn to do it and we develop, and as we get older we get more frail at it. It's something that's really important. An individual gait pattern is influenced by your age, personality, mood, and socio-cultural factors. So the likes of in Japan, where they do a lot of Tai Chi, that would be, or things like that would be very influential on their gait pattern. And with advancing age, the proportion of patients with multiple causes and combinations, such as hip and knee osteoarthritis, gradually increases as we get older. So older people who are frail can be thought of as a complex system that struggle to adjust to minor stressors, which people who are not frail don't struggle to. They can adapt much quicker, they bounce back, and their health is probably a little better there. Okay, so let me see if I'm on the right slide here now. Okay, yeah. So our immobility is, as we said, one of the frailty syndromes, and functional capacity declines with age, and also low levels of physical activity, which we saw during the whole cocooning, and we're probably still going to see an awful lot more complications from that, people's functional decline. And also it was on a 24/7 news feed about, like we're a year into it now, and it's only, like all of us, we can look back and think that it was on non-stop. So the fear and the terror of going outside the door and catching it obviously would naturally restrict anyone's movement, and when they're being advised as well to not move as well. Both our strength and our muscle power, that all reduces as we get older, and our muscle power is reduced by about 30% per decade. So when somebody falls, what happens? So if somebody has fallen, not always, but usually there is a fear of falling then that will follow that person. So it's well documented in the literature about the fear of falling. So unfortunately, the adverse effects of the fall is leading to a self-imposed limitation in an older person's mobility. So 1 in 4 Irish people report a fear of falling, which is twice as common in women as men. And also frailty is twice as common in women as men. So our cycle of a fall here is our fall, then the fear of falling, then limiting your walking, then your decreased mobility, and then repeated falls. So the confidence, that's just not to get somebody, and I know anyone trying to get somebody and increase their confidence to get walking again, people, can be very, very shook by that. So what is Ireland's response to frailty? Well, we are actually doing very well in what we're doing in international standards. This is the work I looked at was just pre-COVID. It was just coming into COVID and the impact of COVID. So our HICWA regulator set standards for older person services, and obviously that's based on evidence-based practice, and frailty has been identified. That is then followed on by our nursing and midwifery quality care metrics, which measures frailty. So that requires all nurses working in older person's care to assess for frailty every 3 months using a validated frailty tool. And I don't know if people have heard of the Frailty Intervention Team, who are commonly known as the FIT team. They usually, but they're not exclusively based in acute teaching hospitals, and that will be members of the multidisciplinary team, such as the OT, physio, social worker, specialist nurses, geriatrician, coming to an older person, generally in AD, but can be on admission within a very quick time to try and identify what areas they need support with the aim of trying to return them home. Because once somebody comes into a hospital system, it really does, their decrease in everything is very, very stark. So the real thing is to try and treat what they can underlying and get them home. So in Ireland, we have, I don't know if many people might have heard of it, it's the Irish Longitudinal Study on Aging. It's called TILDA, and it's run in Trinity by Professor Roseanne Kenny, who's the principal investigator and a real power horse on all things frailty as well, and the National Clinical Programme for Older Persons. So TILDA, early on in its research, discovered frailty in the Irish population. So TILDA is just looking at how the population's aging, informing our policy, informing our health services. What do we need? What's happening? What's coming down the line? And what do we need to prepare for? And frailty, one of these specific areas that was identified very early on. So the theory practice gap is perfectly illustrated here. They went together with the NCPOP, which is Deirdre Lang and the Director of Nursing there, and they came together and they formed a teaching program. And that teaching program was called the National Frailty Education Program. And that directly addressed the theory practice gap. So we have the theory, we know frailty is there. What are we going to do with our work? How are the health service going to facilitate, and also this aging demographic? So it uniquely set up the National Frailty Education to train professionals on frailty, and no other European, there's no comparative study with this that compares other European countries. They've done other things, but nobody progressively and proactively tried to teach our healthcare about frailty like it actually happened in Ireland. So there was no comparable studies to compare it with. It was an innovative method of teaching a selected number of health professionals. And this part is always complicated. No matter how many times I write it, I still can't get it in my head right. So basically, I'll say it from my perspective, I became a frailty facilitator in 2017. So I went and did a 2-day training. One was in TILDA, where I saw how an active research was conducted with the participants, what they did. Very, very informative. And then I went with the NCPOP and learned about the whole day of frailty components. In that study day in the NCPOP, I was hooked up with other than frailty facilitators, and we became a frailty network. And that frailty network, like, we went back to CHO, DNCC, and we thought in our local areas. Now, I knew none of them beforehand, they didn't know me. So it was a great way to see somebody from James Connolly, somebody else in the community, some nurse educators. So a whole load of us, we met as a network and started rolling out these programs to teach the wider community of everyone about frailty. And what I looked at then is the impact of that program on practice. So, we're running the practice, but is it working? Are we doing anything with it? What's the impact? And the first thing was, it is such a complex process translating research into evidence-based practice. It's mind-boggling how difficult that process is. But it was done quite well in this instance. The majority, I looked at it really from the frailty facilitators and the network's perspective. That's the people I was key looking at, because they were the ones who were driving the change. They were all in clinical practice generally, so they were the sample I was interested in. most enjoyed attending Tilda because they could see the research, they could witness it, and they kind of understood it. There was a very clear impact as well, both subjectively and objectively, to practice from sorry, I've lost my train of thought there for 1 minute. Yeah, there was a very clear impact as well. There was widespread use of the frailty instruments, in-depth frailty assessments, although it did vary from place to place. I went all around the country and I interviewed 5 different focus groups. So I had regional, I had urban, rural, I had, you know, so it was a nice mix and a nice contrast of people there. The frailty networks that did really well in delivering these programs and make an impact in practice were the ones that had a centre for nursing and midwifery education to enhance the program's success. And they really were pivotal in some areas. But really crucially, the network grew and it learned from each other. It made much more stronger professional alliances, and it bridged the void between community and hospital settings. So you could have a physio out in the community who had no idea who people were in the hospital. She might have been emailing them and talking to them, but she never met them, or there was never a reason for her to connect with them.
Sorry, Fiona, this is Caroline. Just to let you know, you have about 3 minutes left, and then there's a few questions as well.
Yeah, and really that was it. People reflected on the practice better. There was better shared understanding, but really it created space for innovation and creativity, and that made, in one instance, a dietitian who was interested in the protein uptake for older persons connect with a physio who's interested in the functional ability. So it made people who are in their practice start to develop their own solutions and how they could work things out and try things. So that was quite interesting and exciting. And yes, that really is it. So really, I suppose the key thing is to remember, identify frailty, early intervention and referrals will lead to better outcomes. The research and practice is critical. So without research, we can't have evidence-based practice. And without evidence-based practice, the research doesn't exist. So it all kind of works together. And I hope that makes sense. And I hope people got something from that. And that's it.
Brilliant. Thank you very much, Fiona. I have a couple of questions. It was a nice presentation. We'll send it on afterwards. Just how can we support older adults to regain confidence that they may have lost during cocooning?
Yeah, that's a really, really good one. I think that's where our skill set is going to come in a lot more, and trying to get people, you know, I know it's a silly one, using it or moving it or losing it, but just gaining confidence again in what they can do and the ability to believe that they can do, and also supporting them well. You know, I mean, that really is critical that we do that. Otherwise, people will just lose that functional ability, and to get it again will become harder.
That's great. We also have a question here. Do you record residents who come out of bed onto the floor mattress as a fall or a purposeful action?
That's a good one. Yeah, that's a good one. Well, I think we would classify that as a fall. As far as I'm aware, in my clinical practice, that's what I would classify as a fall. I like onto the mat as well. So yeah, I would say we'd record that as a fall.
Okay. Do you think vitamin D is sufficient as a bone protector in the over 80s to avoid side effects from other bone protectors in this age group? Side effects, sorry.
Yeah, definitely, without a doubt. And that research, Tilda, if you look at the website there, they have loads of stuff coming out. But yeah, absolutely, vitamin D, taking it myself now as well, key. It's a key thing to ensuring bone health. Obviously, the earlier you take it, the better. But they are looking about having it prescribed for older population as well, routinely, that they all take vitamin D. Yeah.
Brilliant. And then, how often the frailty assessments are required to be performed within the community?
It really is 3 months. That's what the metrics are saying. That's what our HICRA regulating are saying as well. It's every 3 months. If somebody's in a very advanced state of frailty, that state won't change. They'll kind of just stay in that state. But if you want to capture the ones early, but generally every 3 months, yeah.
And where do you get your information, or where can you you mentioned an app. Where do you download the app from?
Just like, you know, your apps on your phone, like your Play Store. It's a clinical frailty scale app. Even Rocket himself, he's really accessible. He does a little chat about it, and it's 9 questions, and then you answer yes, no, yes, no. We're using it in our place at the minute, and I'm teaching everyone to use it. So yeah, it's very easy, very simple to use, very user friendly.
Brilliant, well done. And that's there is somebody asking, do you run a frailty clinic?
Oh, well, we'll see. I think we'll have to look. Actually, there's one final thing I forgot to say. There's an MDT podcast as well. It's on Spotify if anyone's interested. And they have loads of stuff on all older persons care. 2 geriatricians run it. So that's another useful resource So yeah.
Okay. So yeah. Listen, there's been great response from your presentation. Everyone is saying it's an excellent presentation. Thank you very much. And then they're saying that it's an excellent presentation and very interesting. So they even got job prospects there, Fiona. People are offering you jobs.
Thank you, Caroline.
Listen, thank you so much. I appreciate it. And we'll sign off now, and I'll talk to you again soon. Take care, Fiona. Bye.